We've all heard the phrase, it takes a village to raise a child. But the thing that we often forget is that it also takes one to support the mother.
Well, speaking of the village, this is our podcast. I'm Nicole Harlow.
And I'm Dawn Thompson. And we're here to connect you with a village of support you need from pregnancy to parenting.
So come on this journey with us as we build your village one episode at a time.
Good day. This is Dawn Thompson. Welcome to Speaking of the Village podcast. And I'm here with my beautiful co-host, Nicole Harlow. And I'm super excited to have my dear friend, Hermine Hayes-Klein, on the show with us today. Hermine, I'm so excited. I mean, even our pre-show stuff just now was just on fire. Listen, you are going to want to listen to this episode. I promise you. Hermine, why don't you give just like a little bit of background about yourself and who you are? Your bio and stuff will be in the show notes, but this is just like a quick introduction.
My pleasure. So my name is Hermine Hayes-Klein. So nice to be with you guys on this Speaking of the Village podcast. I'm an attorney. I'm based out of Portland, Oregon. And for the last 15 years or so, I have been working on issues relating to human rights in maternal health care. And I have a law practice that focuses on advocacy for patient rights, pregnant patients' rights in all settings, and on reproductive choice and access to midwives, doulas, birth centers, and other options for childbirth.
I love it.
Excited to be here with Dawn and I. You and I have done so many advocacy efforts, initiatives, and campaigns together over the years here in the United States. We have a lot of, we've had many conversations, so it's really thrilling to just continue the conversation with you.
Yeah, for sure. I mean, I think that you and I are, we attack it from a different angle, but I think it's always nice to just have someone that totally gets it and gets it even beyond what I get. I think you just have you have just the legal association to what informed consent looks like and the trauma that some experience to the extent of having a legal action against providers. And I love the fact that, let's just dive into that a little bit, because we're going to get into more of, direct informed consent and how it will pertain to you as the pregnant person who might be listening or watching today. But, one of the biggest things that connected you and I was the Kimberly Turbin case. Right. And that was the first case in the state of California, or maybe even in the United States, of an assault and battery against an obstetrician. And that might surprise people. But you can actually Google search Kimberly Turbin. Her case is widely known in the media. It was horrific. I mean, and it was all caught on video. It was a forced episiotomy without informed consent. And in fact, I warn you about going and watching the video. It's very, very difficult to watch. But, she just says over and over again, please don't cut me. Please don't cut me. Why are you cutting me? Don't cut me. And then he proceeds to cut her. Not only does he proceed to cut her, but he cuts her punitively 12 times. And, this is obviously an extreme case of informed consent violation. And it's what movies are made of, right? But let's dive into what that really looks like on a day-to-day basis with the average person in obstetrics.
Okay. I mean, so like you're saying, Dawn, we come at this from similar and different perspectives. I think through the lawyer lens, but at the end of the day, you and I both came at this thinking about what we were hearing from people, from women about their experiences of childbirth, and just from listening to women talk. And I was doing it sort of, both listening to friends, but also starting to study women's experiences of childbirth in different places. And you, through your advocacy as a doula and then the leader of Improving Birth, you were hearing from thousands of women. And I think what brought us together is the realization of how much preventable harm was occurring. And, of course, as you say, this is not about most people, but it is about a big enough group of people that this is a lot of preventable harm. Luckily, most people get through childbirth okay. But a lot of people that we were hearing from in our work were coming out injured, physically injured, traumatized. And, you know, for myself, before I met you as a lawyer, what just started to occur to me in hearing all these stories was the common thread of how often they involve the violation of informed consent. Because again, like hearing the stories, but as a lawyer, I'm aware, wait a second, they don't get to do that to you. Like patients have the right to make all the decisions about their care on the basis of accurate information about their alternatives for treatment and the risks of each of those alternatives. And doctors' expertise or authority does not give them the power to decide what's going to happen to a patient. Like that's not what they don't get to say. Because so often, including in the case of Kimberly Turbin that you mentioned, literally at the moment when the patient, in that case, Kimberly, is saying, wait, doctor, why do you want to cut me? Asking for information, wanting to understand if he needs to cut her and why, instead of answering those questions, he said to her, wait, I'm the expert here. So why are you even asking those questions? And like legally, that's illegal. They don't get to say their expertise gives them the authority to treat you, but it doesn't give them the authority to make decisions for you. And that is such an important distinction. So I just started to realize, wow, so much of the trauma and injuries that we're hearing about could be prevented if doctors would simply follow the law. And the fact is they're not following the law. Like, you know, so one of these questions that I think you and I have talked about for years is like, how much would change in labor and delivery if before anybody did things to the body of the birthing woman or her baby after it's born, they looked her in the eyes. They told her what they wanted to do and why. They told her what the risks are of that thing, honestly, with, you know, balanced, objective information. They told her what the alternatives were with honest, objective information. Nobody was trying to push or steer her, but they were just supporting her and making a decision that's best for her. How much would change? And then, and patients were actually supported in that kind of a way to make their own best decision. How much of the harm that we heard about could be prevented, and how much would change in that room? And just that difference of like what a drastically different room it would be if that were happening tells us a lot about that gap between the culture of what's happening in hospitals and the culture of medical obstetrics and sometimes midwifery and the law, which makes really clear that that's what's supposed to be happening every single time, and yet it's almost never happening. So fundamentally, my advocacy work is trying to close that gap, and yours is as well, from different ways, including you trying to basically inform and educate patients about their rights and about their options so that they can be more empowered as they go through the process.
No, totally. And I think that one of the things that came to me when you were talking about was this quote from Dr. Rana Oddish, who wrote In Shock. I don't know if you've read it, but brilliant book. And, you know, one of the things that she says is that in medical school, they're basically taught to steer you in whatever direction that they think is best. And it doesn't have anything to do with real, true informed consent. And the thing that I learned as my doula work went on, and ultimately it's what's driven everything that I do today. That includes the podcast, starting Birthify, like all of those things were driven by this. And that was over and over again in the first 10 or 15 years of my doula work, when I was helping people one-on-one, was how often second-time parents hired me, because frequently I was very commonly did VBACs. Like I just became a referral in the VBAC community, vaginal birth after cesarean, if people don't know what VBAC means. And so my number of second-time moms was very high. And it was amazing to me how many people said in some fashion, if I would have known this, I wouldn't have done that. Right? Like if I would have known that getting an induction increased my risk for C-section, I wouldn't have done it.
Right.
If I would have known that just having gestational diabetes didn't mean I had to have an induction or a C-section because I was controlling my blood sugars the whole time, it was fine, and like they're never, and that's the thing. It's like, oh, well, we're just you've got gestational diabetes. Oh, we're doing an induction at 38 weeks or 39 weeks, whatever it is. It's just like across the board, instead of like treating each person individually and saying, oh, but are you managing your thing? And by the way, at 39 weeks, how favorable is your cervix to induction? If you're a 0 Bishop score, it's not a good idea, like, anyways.
Right. Well, exactly. And what you're talking about, again, like from the legal lens, it's like, if there's a piece of information that if you had it, you would have made a different medical decision, you had the right to that information before you made the medical decision. And the fact that you made that decision without that information means that the doctor violated your rights. And so, so it's like, why does this matter is like an important question for the context of this podcast. And that's because, the question is, do we think that the law of informed consent matters and that it matters to pregnant women about whether they get to make that decision? And the fact is, like, some patients might be like, you know what, I just want to do what the doctor says. And they have the right to say that. But the doctor doesn't get to say, most of my patients just do what I say. Therefore, I don't have to tell the patient who does want to make that really active decision. Yeah. That's not the way it works. And what the doctors need to understand is that if they're with a patient who's like, I trust you, I just want to do what you say, that patient still has the right to change their mind at any time. So, and to ask questions at any time. It's not like they can lose their rights. Nothing waives your rights when you walk into the hospital. Or at any time, because what we're talking about here at the end of the day is our most sacred right, which is the right to control our body and what's done to it. And we retain that right all the time. The only time we can't exercise it is if we're unconscious. And that's why the law provides that if you go unconscious or if something happens that makes you mentally unable to make decisions, that the law looks to your next of kin or your guardian to make the decision at that point. There's no circumstance in which the law there's one circumstance in which the law will allow the doctor to make the decision, and that's if the patient is unconscious, there's a life-threatening emergency, you know what I mean, and there's nobody else around to make the decision. Like, so that's the ambulance just rolled in, there's nobody here, you just got hit by the bus in the street, the doctor can help you if you're knocked out. But if you're not knocked out, the doctor has to ask you, even if the treatment would save your life. And so I think it's one more thing that's really important to mention in the context of childbirth, that includes when you're pregnant. There's nothing about pregnancy or the fact that there's a baby in there. A lot of what people say when we're talking about informed consent and childbirth is, well, who's looking out for the baby? The answer is the mother, the person who's gestating that baby. That person, it has the legal authority to look out for that baby, and nobody gets to take that right away just because the pregnant patient is disagreeing with their doctor. That's not how it works. You get to disagree with your doctor without losing the right to medical decision making. And if anybody's unsure about, well, does that include if the doctor is trying to save the baby's life, then I would recommend, and you could put in your show notes, the American College of OB-GYNs has issued a great ethical opinion to obstetricians about the importance of respecting pregnant patients' medical decisions, including their right to decline any intervention, and even if the doctor thinks it's going to save the baby's life. And that's ACOG's ethics committee from 2016 called the Maternal Refusal of Medically Recommended Treatment. And one of the things that they explain in that is, listen, doctors, you must respect your patient's decisions. And not only that, but you have to support their decision-making process without manipulating them, pressuring them, coercing them, threatening them, or forcing them. And those all mean different things. And it's worth thinking about it, because manipulation means I'm going to manipulate the information to steer you into what I want. It's the most common.
Which is what we see most common
form. And what they explain in the ethics committee is, why is this so important, doctors? Because two big reasons. One, prognostic uncertainty. You might think baby's going to die, but guess what? We're often wrong about that. And there have been many cases where doctors literally called judges to get court orders to force women into cesareans. The women escaped out of the hospital, escaped cross lines, and birthed their baby vaginally just fine. So it wasn't the case that the doctor was wrong. Prognostic uncertainty. And then the second reason is the limitations of medical knowledge, which is a little different. It's about prognostic uncertainty is, I might be wrong this time. Limitations of medical knowledge is, well, we might think that C-section is safer than vaginal birth for breech, but you know what? Our studies evolve all the time. We might think that it's reasonable to offer induction of labor at 39 weeks and that it has no impact on C-section rates. But you know what? Studies evolve all the time. And so, we actually are learning in process about the risks and benefits of things. And we need to have a little humility when we're counseling our patients and to support them in being able to make those decisions.
Mm-hmm. I think that we should really talk into like some of the basics of what coercion and manipulation often looks like. Like I had one provider, I'll just share this story because I think it'll be a perfect anecdote. I had a provider that I used to work with regularly when I very first started doing my doula work. She was wonderful. I really loved her bedside manner. She was kind. She was all these things. She was supportive of my clients wanting to go unmedicated. But after a little while, I realized that she had a pattern. And at 36 weeks, every single one of my clients, she would do an ultrasound and she would say, "Oh, that baby's looking really big. We're probably going to have to do an induction at 39 weeks.
Wow.
And she would do it at every 36-week appointment. And then at 37 weeks, she would do something else to reinforce that and have that same conversation. Come 38-week appointment, she'd be like, "Oh yeah, for sure. Baby's big. We need to go ahead and schedule your induction for next week." Wow. And I saw it over and over and over and over. And what was happening was many of the families that were hiring me because they wanted an unmedicated normal physiological birth. They wanted to do everything naturally as possible. Mm-hmm. And so, of course, this didn't match up, and they would call me and they'd be so beside themselves, crying and being like, "She told me I have to do an induction. I really don't want to do an induction." Right. And I would then have to, she said the baby's big. And then I would have to sit there and counter their doctor.
Wow.
And that was really difficult to do.
Right.
And it was ultimately at the time felt really inappropriate because I was definitely stepping outside of my scope as a doula, because now I'm saying, okay, you should go against your doctor. And obviously from an ethical standpoint, I didn't feel good about that. So eventually what happened was I just started preempting her. And I would say before they even got to that, and sometimes even just when they would hire me, because sometimes they were hiring me at 34, 35 weeks and they were about to have that appointment with her. And I would say, "Listen, I love her. She's so good bedside. She's an amazing human. But here's the thing that she does. And it's just how she likes to practice. But here is the information for what science says about inducing for big baby, what your risks are of this procedure, what your risks are of waiting, and I would just give them all this information. And I would say, here's the information to read up on. And you need to read up on this before you have that doctor's appointment, because I'm not going to tell you what to do. I'm just giving you the information." And then what would happen was they would go in and have this conversation and she'd say, "Oh, that baby's big." And they'd say, "Oh yeah, we read the ACOG guidelines on induction for big baby. And it's not really supported by science. I mean, do you really think that the baby's going to be over 10 pounds or 11 pounds? And then of course she would have to say no. And guess what? It stopped her in her tracks. She would just go, "Okay." And then she would follow it up with, "Okay, great. But just know that if you wait for labor to start naturally, I may not be able to be your doctor." And suddenly it all became clear, because what a lot of people don't understand is that doctors only get paid if they do the delivery when they're in a group practice, because for insurance, they send a super bill and it's only done and it's billed. That super bill is billed under who that provider is that did the actual delivery. It doesn't matter how many office visits you did. And there's some places that are not doing it that way anymore, but that is the most common. And so then it became clear why she was doing this. She was wanting to schedule as many of her patients on her days so that she was the one getting paid. And none of these people needed induction of labor at 39 weeks.
And it's hard for people to understand, it's a lot of people can are pretty shocked when they realize that a doctor would recommend a treatment for any reason other than that because they need it. But folks, unfortunately, we've got decades of studies that people can easily Google showing that the C-section rate is affected by physicians' financial incentives, their time convenience incentives, and just plain old their preference for delivery. But the problem is that's never how it's explained to the patients. The patients are never told, we just prefer C-section, or we just prefer to induce people. They're led to believe, and often in kind of circular, confusing, gaslighty logic, that they need it, or that their babies are going to be in danger if they don't do it, when in fact, often the treatment that's being proposed poses more risk to the mother and the baby than not acting at all, than letting the physiological process continue.
Yeah. I mean, that just makes me, I'm having a brain fade. That just makes me think of the ARRIVE trial.
Right.
And how the ARRIVE trial, I knew we were at Women Deliver in Denmark at Copenhagen together when the ARRIVE trial was shared on the main stage at ACOG. And
right.
You and I got word of it while we were there. And I don't know if you remember this, but we were talking to the president of the Denmark version of ACOG. And I said, what do you think of this? They just announced from the main stage that a study said that all women basically should be induced at 39 weeks to reduce the C-section rate. And he looked at me and he said, that's insane. And I said, you're right. I know. And yet, you know what's going to happen? It's going to explode. And I knew it. It takes an average of 17 years for evidence to become practice unless it serves the system. And I knew it was going to take off, and boy, has it. And now, thankfully, we had an episode with Dr. Feinberg. She did a study and showed that the risk of C-section because of this ARRIVE trial has jumped 67%, that risk.
Right.
For surgery.
Exactly. Well, and I mean, I think there's another study that you could talk about. So that point that you just made about the system will change, that evidence is not adopted in practice quickly unless it benefits the system. I think you need to spell out that a little bit more, but because by the system, what you mean is the convenience and profit of the hospitals.
Yes.
Even when that doesn't line up with the interests of the pregnant women and their babies. And so what you're talking about is, for example, the ARRIVE trial led to the very quick decision on the behalf of American obstetricians to start pushing women into induction of labor at 39 weeks and telling them that they could avoid a C-section by being induced at 39 weeks. And similarly, 20 years ago, one very flawed study came out that suggested safer short-term outcomes for babies from C-sections for breech as opposed to vaginal birth for breech. And on the basis of that, suddenly women were told, you're not allowed to have a vaginal birth if your baby's breech. Your only option is a C-section. Turns out that study was inaccurate. Turns out there's risks and benefits on both sides of C-section and vaginal birth for breech. And that too is a decision that patients deserve to be accurately informed about and to make the decision about. But yet there was this massive shift in practice because it was beneficial to the providers.
Right. And in massive, like in whiplash, within a year, it was.
And I think a very important study on that point, again, induction of labor, most women are being told recommended induction of labor if they're in care of obstetricians now in the United States. And so again, I don't know if you already talked about this on this podcast, but of course, the United States, we're both the wealthiest healthcare system in the world and the only one in the industrialized world with rising maternal mortality. We've got better improved outcomes to show for all this explosion in induction and the use of C-section. And there's a study that I think you should put in the notes here together with the Annette Feinberg study you mentioned. And that's a study that came out in 2022 by Neil Shaw, Eugene DeClercq, and and some researchers in Holland and England that looks at, I don't know if you've seen this one yet, gestational age in 2022 or 2020 compared to, say, 1990, the change in gestational age. And what these guys show is that in the United States, not in England, not in Netherlands, but in the United States, the overuse of induction has now changed the average length of gestational age from 40 weeks to 39 weeks. So like the actual length of pregnancy has been artificially changed by obstetricians. And what that study also shows is basically, you know, in the hospital setting, it used to be lots of people made it to 42 weeks of pregnancy.
Right.
Nobody, hospital setting, almost zero people do now. They're not allowed to make it to 42 weeks of pregnancy, and it only really happens in the home birth setting. But again, medical obstetrics cannot show improved outcomes that have resulted from all of those interventions. And instead, there are invisible costs that are mostly borne by the women themselves who come out injured after the childbirth and are told, congratulations on your healthy baby. Sorry, your body didn't failed the induction, and good luck to you. And so those are the problems that you and I are trying to address or avoid by helping people to understand their rights so that they can make those informed decisions to accept or decline induction or any other intervention that they're offered during labor.
Right. And like, go ahead, Nicole.
I was going to say, I think also like something to talk about is, yes, induction, say no if you don't want it, like you have the decision, but there's so many other like little things I think throughout the pregnancy that we just go along with and we don't think about even saying no. Like Dawn, what you were saying with the 36-week ultrasound, right? I remember with the episode with Dr. Feinberg, most of the time that ultrasound is not necessarily useful in anything, but it gives the big baby excuse for induction. So if you just said no at, oh, I don't need a third trimester ultrasound unless there was some kind of high risk right before. But if it's just a routine, saying no to an ultrasound is a lot easier, I think, as a pregnant person, like pregnant woman, to then say no to an induction, which is, it feels like this big weight, like, wait, I'm doing something wrong. I'm going against this big thing that the doctor's recommending, where like saying no to an ultrasound may be a little bit less difficult for someone. And additionally, like I know friends like that have declined the 3-hour glucose test and just like did some finger pricks instead of, that artificially inflated glucose, like things like that again, kind of put that power back in, or the ball in your court, I guess you want to say, or it doesn't give that power away to then be susceptible for that grooming of the induction.
But how often people complain about the current healthcare system, right? They go to the doctors, they're frustrated with the doctors, it takes them too long. And then the only thing that the doctor does is, in most cases, and obviously whenever we're talking in generalization, we don't mean all, don't come at us about it, but in a general sense, people are upset with the healthcare system because the healthcare system is just pushing pharmaceuticals, right? You come in and instead of trying to figure out what's wrong with you or why you're having this challenge, why your gut hurts all the time, they're just like, here's some Prilosec, or whatever it is, right? Zantac, like they're just giving you more pharmaceuticals instead of actually addressing the issues. And yet, when it comes to maternity care, people act like this isn't the exact same healthcare system. I mean, like the amount of people that I get on the TikTok channel saying, oh, you should just listen to your doctor. Like, oh, do you have a medical degree? Like, oh, do you, how dare you tell people this or like give them this information? And it's mind boggling to me. Why do you think that is?
Because people have a cultural belief that childbirth is injurious, that it's very, very dangerous, that it causes injury to mothers, that women are lucky to survive it, and that they only survive it through medical intervention, so that the best thing that they can do is turn themselves over to the physicians and do what they say. But that's not what, unfortunately, that's not what the evidence shows. And again, like we talked about, women, all patients have the right to just do as their doctor says, and they don't have to ask questions. They don't have to know about alternatives. But also all patients have the right to be accurately informed, and the duty is on the doctor to make sure that they get that information, that that they're offered that information and the support to make that decision. And I think something that we need to make clear here is that what we're talking about here is not about your opinion or my opinion or Nicole's opinion about induction of labor or cesarean surgery or any given medical intervention, because all we're talking about is making sure that every patient has the right to knowingly choose their health care and the healthcare that's best for them. And so a C-section that a patient knowingly chooses and feels is the right thing for their care, that's healthcare. I think we would all agree. And what the studies show is that does not cause trauma. Ditto with induction of labor. If the patient feels good about an induction and understands, that there are risks, and knowingly because as you guys have talked about, in all the choices that people have to make during pregnancy and childbirth, there's been no risk-free option. You know what I mean? There's basically, childbirth does have risks, and there's risks with every option. The question is, which are the risks that you choose? Do you want to take on the risks of a repeat cesarean, or do you want to take on the risks of a vaginal birth after cesarean? Either one has risks, and you have the right to be accurately informed and to make that decision. And so when women choose a repeat cesarean and its risks knowingly, and some of those risks play out, they're far, far less likely to be distressed and traumatized because they understood and they accepted that they were taking on those risks. Ditto with a uterine rupture or the risks of a VBAC. If the person gets to make that decision and be supported in that decision, it's not about that they had a VBAC or a C-section or not an induction. It's about consent. And that's just like with sex. Consent changes the nature of an interaction that we would have sexually with somebody, from something bad to something good. With consent, it's something good. It's sex. It can be lovemaking. Without consent, the same actions have a very different impact, right? And so it's so it is with healthcare. So all you and I are talking about here is consent, and wanting people to understand that they have the right to make those decisions, and that making sure that they can exercise that right is one of the best ways to come out of childbirth as healthy physically and emotionally as possible.
Well, I think about that too, because obviously people think I'm anti-induction, anti-C-section, anti-establishment, all those things. And I get that, because I don't always follow up everything that I do with saying, I don't care how you give birth. I don't care. I'm not attached to the decision that you make. What I'm attached to is that you have the information to make the decision. And frequently the care system is not giving it to you because they don't have time.
Yeah.
And because it doesn't work into their business model.
Dawn, I don't think that people that know you think that you're anti anything or that you push any choice. I think what you mean to say is some people who are new to my podcast might have the impression that I have a preference, but anybody who actually knows you and your work for the last 15 years knows that you are not at all about trying to push any choice at all, but all about supporting each individual in having their healthiest and most empowered birth by understanding what the real evidence is and what their rights are.
True. You're absolutely right. I mean, I think I've support, I live in a military family. I mean, a military community, and the number of families that have chosen induction of labor because the partner is about to be shipped out, right? And they're going to be gone for months. I support that 100%, right? I get it. And they're willing to take the risks, and I'm willing to take that risk and support them in that risk assessment and through that birth process. And if it ends in cesarean, they know, they're like, I knew it was a possibility, but I'm so happy that my partner got to see our baby before they deployed. And I love that. And I think I'm going to just help her with all the things that she's going to need to know about recovering from a C-section, right? Like my support doesn't end because she did something that maybe I might think was more dangerous or something. Like, it doesn't matter. It doesn't matter. Right? I mean, that the thing is that what we want is that people just understand their options, and they're just not getting it from the system. And even though, like you said, it's the law, many obstetricians have no idea about the law, right? I mean, like, how often do you see that?
Even though their hospitals have an obligation to make sure they understand the law and are ready to follow it for their patients. But I think also that point you just made about, like, you know, can somebody look at somebody else's medical choice and say, you're making the more dangerous choice? In fact, I know what you really know, Dawn, because you and I have talked about it so many times, is that, like, nobody's in a position to judge what's safer or more dangerous for anybody else. You know what I mean? Because basically it's like, I could see two medical options and say, for me, option A is safer than option B. And you could look at the same two medical options and decide that option B is safer for you than option A. And that it can both be true, because what is safe for you and what is safe for me is a function of a lot of variables that are both the differences in our bodies, the difference in our medical history, but also our circumstances, our family support, our past trauma. All those things get to weigh in. Like, the law that's why the law lets patients make the decisions, because we get to make those decisions about what's safest for us on the basis of our personal circumstances. And I know what a doula you are, in addition to an advocate. And as a doula, I know that you're all about that. It's not my job I can't know what's safer for her unless I listen. Right. And that's why at the end of the day, the obligation, what every birthing patient really needs is to be heard, throughout her care and throughout the postpartum care. And part of what I think a message that we want to make sure folks get on this podcast that we're talking about today is, again, like, it's not normal to come out of childbirth injured. You know, childbirth is a process. It's intense. It can hurt a lot while it's happening. But when it's over, your body should be okay. Like, we're made to do this, to, like, go through the intensity of the baby coming out. And then the body there can be some aches and pains for a short amount of time, but those should heal, y'all. Many people literally don't know that. They think to be in pain after childbirth is normal, to have a broken bladder after childbirth is normal, to have trauma symptoms and nightmares after childbirth is normal. Those things are not normal. And so if you go to your postpartum OB appointments and you report, I'm in pain still, my body's not okay, and or that I'm having any kind of I'm not okay emotionally, you should be getting treated. And so that, like, if they say, well, this should fade with time, then they should be tracking it. And we're going to watch this and make sure, and we're going to bring you back in to make sure. They shouldn't say, good luck, it'll probably fade with time.
We'll see you with your next kid. But that's it, is they only get paid for that one postpartum visit. So they're not inviting you back.
Well, it's their duty to make sure you're not injured. And so what we would all want to make sure that listeners can hear is that, you know, if you're not okay after childbirth, seek help. And if the people who did your birth are not offering you that help, look somewhere else. Don't go home and curl up in a ball and wait to get better, because far too many women do that. And it goes to dark, dark places.
Well, and you know, that comment that I just made of, like, oh, they're only getting paid for that one postpartum visit. You know, I don't think people understand how much the financial system of healthcare, if insurance, impacts the type of care that you get, and how people might try to just brush you off to the next provider. And, like, for a lot of obstetricians, that 6-week appointment is it. They're done. They're wrapped. They're done. They're done. And if you've got any further issues than that, you need to go see someone else, because we can't bill for this. Right?
Yeah, that's exactly right. Exactly. You're right. You're supposed to get what you need, regardless of the payer model that's driving your care.
Right. And I think that it is I feel like the biggest thing that I want people to get out of this episode is that, first of all, informed consent means that you're being given the risks, the benefits, the alternatives, and the right to say no.
Exactly.
Right? You have the right to say no to anything. And I don't want people to, I mean, there are circumstances when induction is absolutely necessary, when interventions are life-saving. So I never want to discount that, because that is true. And there's a lot of providers who would come on here and say, you know, there's a lot of dysfunction in our healthcare, in our people in general, and it's contributing to all those things, and we're not talking about that. But that might be another episode about nutrition. So do you have a hard stop at 10:30?
It would be good. Yeah.
Okay, great. Okay. Well, we've got just a couple more minutes, so we could just wrap up. But
Okay.
what is the thing you feel like after this conversation you want to be the thing that people get out of this episode?
That understanding their right. I mean, we might want to add understanding your rights and having a doula willing to support you in the exercise of those rights is the most effective way to avoid preventable trauma in childbirth.
Yes. The only other thing that you mentioned that I wanted to say too was that you had mentioned about how sometimes information is that, in a study about trauma.
Mm-hmm. Oh yeah.
I think the most common thing was the lack of information was what caused the trauma.
Oh, I'll say it, I can say it even more clearly. What the studies show is that what makes the difference in whether a woman are we still recording? Shall I go ahead and say it?
Yeah,
Okay.
yeah.
So there are a lot of studies on maternal trauma because we as a society are starting to recognize that maternal mental health matters as well as physical health. And in fact, in the United States, mental health is the #1 cause of death for mothers. So trauma and PTSD matter very much and need to be addressed. And what the studies show about childbirth related trauma is that it's not about mode of delivery. So again, get to the point. This isn't about C-section or induction or how the baby's born. Whether a woman comes out of childbirth traumatized or not comes down to whether, no matter what happened during the birth, she felt in control. And by in control, we don't mean that nothing surprising happened, because surprising things happen in birth. It means that when the surprising things happened, she was treated as the captain of the ship. People said to her, listen, so this is what's happening now. This is what we see. Here's the new issues for us to think about in terms of risks and options. Here's what we want to tell you. What do you want to do? And even when scary things happen, if something like that happens, people might be distressed. They might even have grief, but they're not going to have the trauma. The trauma comes from being rendered helpless at a time of where the stakes are so high. And I talk with strong women who sob, talking about their effort to just make a decision about induction. And they're asking questions and they're being told, no, you're fine and your baby's fine, but it's just our very strong recommendation. And they can't get the info, and they feel like it's such an important decision being made, but they're not being allowed to understand enough to participate in that decision. And that can leave people with this very deep sense of helplessness in a time of vulnerability. And that is what is related to trauma. So, I think part of what we also want to help make sure folks know is understanding your rights is very important. Knowing that you are the captain of the ship, period, no exception. Period. And also, a doula can be a very valuable advocate and ally. And maybe we'll do another episode in the future, Dawn, on that topic, the role of the doula in supporting the patient's legal rights. But if you have a doula who also understands your rights and understands some of the medical facts and the way that you were describing, Dawn, being able to do for some of your clients in the past, talk about what are the studies, but more than anything, a doula who will make sure that your voice is heard in labor. That is probably the most powerful tool you can bring in there to avoid preventable trauma and ensure that you get the healthiest birth possible.
Yeah, it's why I created Birthify. It is trying to make it affordable for people who cannot afford an in-person or don't want someone in person, but still want the knowledge and deep information. It's exactly the whole purpose of everything I do and every day that I wake up. Now, this is going to lead to our final question, Hermine, because I think you already just answered it. But what do you think is the most important person in a pregnant family's village?
Oh,
aside from you.
I don't know if you're talking about like what advocates or activists have been effective in the United States, or just like who do you need if you're pregnant? If you're pregnant, what you need is a doula.
Yeah.
Yeah. And, as for the advocates in this space, it's like, it's you, Dawn, and everything that you've done for as long as I've known you. It's been over 15 years you've been doing this work, and it's taken many powerful forms over the years. I think you've had an enormous impact. And Kristen Piscucci, our old colleague who then created Birth Monopoly, has, I just hear from a lot of women who use those resources as well to try to understand their rights. So we've all been walking this road together, for a decade here in the United States, and we're going to keep at it.
Yeah.
Hand in hand.
That's right.
That's right. Yeah.
Right. Now we just need to get back to Brighton Bush.
Yes, please, girl. Anytime. So leave it all to heal.
I know. Hermine, I love you so much.
I love you
I
too.
knew this was going to be just a dynamic, incredible conversation. I cannot wait to do it again. Let's get you back on here. It's always so good to
Always
chat with you about this stuff.
We'll do another one soon.
Okay.
So
Hey, y'all, there's going to be lots of show notes for this one, I think.
Great.
So please share this episode. I think this is probably going to be one of the most important ones we've ever done. So please share it with your friends and any pregnant folks that you know. Thank you so much for being on the podcast, Hermine, and I look forward to having you again. And this is Speaking of the Village. Thanks for listening.
Have a great day, you guys.
Hey, thanks for joining us on Speaking of the Village. If you loved today's episode, make sure to hit subscribe and share it with a friend.
And remember, you're not alone. We're here, we're listening, and we're all in this together, because in our village, no mom walks alone.